Next lecture by Dr. Amal. He is going to speak on OCT. I think he has been doing it for some time, and he's going to tell us OCT and other intravascular imaging modalities. What do they tell us? Thank you very much.
Very good morning to everyone. That was an excellent talk by Ajit, and I think he summarized it very well about the role of FFR guiding revascularization and about IVIS optimizing revascularization. I think OCT once again falls probably more in the optimization group. It probably doesn't have as much data as IVIS does, but I think it just has enough data to start using it for clinical practice, and I don't think it's just a research tool any longer. As you know, there are various intravascular imaging modalities, but I'm mostly going to concentrate on OCT today, as the other modalities like angioscopy or near-infrared spectroscopy and intravascular MRI are still, some of them are out of practice, and intravascular MRI, I think, may have a future, but it's still on a very infantile stage. I know some of you are probably not very familiar with OCT, so I'm going to cover some basics on OCT. OCT is just an optical imaging modality that uses near-infrared light to create high-resolution images of the intravascular tissue. There are two types of OCT. One is the time domain OCT, and the second one is a frequency domain OCT. The existing model, the C7, is a frequency domain OCT. The problem with the time domain OCT was the acquisition rate was a bit slower. The frames per second were only around 20 compared to frequency domain, it's about between 100 and 200. And more than anything, for the time domain, you needed balloon occlusion, which is quite cumbersome, and now that's been replaced with the FDOCT, which just requires a flush injection with contrast to flush away the blood. And how does it compare with the IVIS in terms of resolution? Clearly, both axial and lateral resolution of the OCT is superior to IVIS, and the OCT, as you can see, is in the order of 10 to 15 microns, where the IVIS is about 150 microns. So what do we do? It's similar, the technique is similar to IVIS. It goes over the wire, and you park it distal to the area of interest, and the pullback is only automatic. You can't do manual pullback. The pullback is actually triggered by a forceful contrast injection to flush away the blood in the coronary. And as soon as the blood is replaced with contrast, the sensor in the fiber optic cable starts rotating and spinning, and you get a 360-degree image of the coronary artery. And the single pullback covers up to 52 millimeters, so you can cover a large area of the artery in just a single pullback. This is how the catheter looks, very similar to the IVIS catheter, but it's a bit, smaller and lighter. So the softness of the catheter sometimes makes it a bit difficult to track. You can easily kink it, so you have to be very gentle. And the other main difference is this purge port with a 3 ml syringe. As I told you earlier, you need to flush the blood with contrast using a guide cat. But before we do that, the inner core of the catheter it needs to be filled with contrast. Otherwise, the light doesn't get transmitted out of the catheter. So you just purge it before you start acquisition by filling the inner core with contrast. The catheter has got a blue tip, and it's a over-the-wire monorail catheter. It has two radiopaque markers separated by 20 millimeters, and the fiber optic lens is about 5 millimeter proximal to the proximal marker. Just like the IVIS, you get a cross-sectional and longitudinal view, and this is how the artery looks on an OCT. You can see the lumen clearly, and there is a guide wire artifact. You can see a guide wire shadow rather, which sometimes can cause limitations and visualization. But with the catheter spinning 360 degrees, it doesn't matter too much because the guide wire position keeps changing during the acquisition. And it does visualize intima and media very well, although in this picture the adventitia is seen pretty well. I should say the penetration of OCT as compared to IVIS is not as great. Therefore, visualizing adventitia and the far field tissue is slightly difficult with OCT, as I will show in subsequent slides. This slide shows the plaque appearance on an OCT. It pretty much shows everything on the... I think here you can see the calcium. Calcium, I should say, is well seen on the OCT with a clear loosened area in the center and a well demarcated margin. And on the at 7 o'clock, you see a fibrous plaque which appears yellow, homogeneous. It has a yellow homogeneous appearance with low attenuation, unlike the lipid plaque at 5 o'clock or 4 o'clock, where you get high attenuation, so you get a dark background beyond the lipid plaque. Macrophages, if you're an expert, you can visualize, which does help in deciding any active inflammation, certainly in a culprit lesion and in a vulnerable plaque and so on. Stented segment, I feel, is probably the best, is best visualized using OCT. You can clearly see the stent apposition and expansion very well on the OCT, and also edge dissection as well identified. But more often, actually, you see edge dissection more than you see on the angiogram. And the question is, what do we do with them? Do we treat all the edge dissection when we clearly will be over-stenting? In my practice, what I do is, if the length of the dissection is short and the luminal area is big enough, I tend not to treat it. So there are some pictures comparing IVUS and OCT. As you often see the comparison pictures, the image of interest looks better than the image of non-interest. So the IVUS images, I would say, is probably not the best one that you get. But clearly on these images, you can see the fibrous plaque much clearly on the OCT, which has this yellow homogeneous appearance and with low attenuation. Calcium, I mean, we all know IVUS delineates calcium very well. As you can see in the picture on the left, there's extensive intimal calcium from 6 o'clock to 12 o'clock. And you can see the same calcium very well on the OCT, as I said, as a central area of lucency with a well-demarcated margin. Stents, as I already mentioned, you can see that very well. You get this classical, like a sunflower pattern or the sun ray pattern on the OCT. You need to remember that the stents, you only see the luminal side of the stent. You don't see the abluminal surface because the light doesn't penetrate. So more often you have to give some leeway to the thickness of the thin strut before you decide on malapposition. So it's worthwhile remembering the thickness of the various DES in particular. But in general principle, if the distance between the luminal part of the stent strut to the intima is more than 0.5 millimeter, you have to consider that as malapposition. Instant restenosis is beautifully seen in OCT. As you can see here, the stent struts are, there's a significant near-intimal proliferation, well recognized on the OCT, which can also be seen on the IVUS, although not very clearly on this picture. Dissection, as I already mentioned, you can see the flap very well and the false lumen. And in this picture, you can see much more better on the OCT compared to the IVUS. Even histology correlates very well to OCT images. That's the red thrombus, which is a fresh thrombus that you can see in an acute coronary event. And the red thrombus, unlike the white thrombus, has this high attenuation. So you can see an image probably similar to what you get with calcium in the IVUS. On the other hand, white thrombus, there is no attenuation, has low attenuation, and you can still see the intima and the media behind the thrombus, and it's much well demarcated. False lumen can be seen very well. This is a case of an androseptal MI where you can see evidence of thrombus. In addition to that, on the picture on the left at 11 o'clock, you can see the plaque rupture and erosion. OCT is useful in studying BMS versus DES. Several studies have used OCT to assess the stent coverage post-stent implantation. And on this picture, as you can see on the left, drug-eluting stents, the near-intimal proliferation on the bare metal stent is much higher than a drug-eluting stent at 1 month. Sorry, it doesn't project very well. So it's 1 month. There are some limitations to OCT, like in this picture. As I told you initially, you need to flush the blood with the contrast, so the artery is filled with contrast rather than blood. If you don't flush very well, this is the appearance you get, what is called as a blood swirl, and sometimes, obviously you won't be able to get any information when you have an appearance like this. Sometimes you can get a blood speckle. This is the light reflected from the RBCs within the blood. More often, it's not a major problem, but sometimes, once again, it can obscure your image viewing. Has OCT been validated? I would say for most things it has been validated. However, there are some new variables identified on the OCT. Nobody knows their relevance in the clinical practice, and clearly it's being studied, and maybe we will get more data about that in the future. For the time being, for plaque morphology, there is good data that OCT characterizes plaque very well. It's certainly stent coverage and stent apposition and expansion, and assessing the diameter, lumen diameter, area, length of the size of the vessel and the length of the lesion. OCT has been well validated. And this study by Yamaguchi on 76 patients showed that the success rate of OCT is pretty good. Before PCI, almost 92% of the patients were able to do OCT. You were able to assess them with OCT. And after PCI, just like IVUS, 100% of the patients, OCT was possible. For stent malapposition, once again, it's a small study of 74 patients, but this showed the sensitivity of OCT for stent malapposition is more than 90%. And on this study, IVUS only had a sensitivity of around 40%. I think this picture, to some extent, tells you what you can see with IVUS and OCT. The picture on the left is probably would explain how IVUS images appear. The near structures are a bit blurred. On the other hand, you see the far field structures are much more crisper because of the better penetration of ultrasound compared to light. Whereas with the IVUS, you see the near things, particularly the lumen and the intima, very well. On the other hand, the media and adventitia on the far field is a bit blurred. I know it's a little bit of exaggeration. IVUS looks better than that. But as far as accuracy and variability, there is good data showing that the luminal length and luminal diameter and length assessment on OCT is fairly accurate, and the variability is very low compared to IVUS. There is a reasonable amount of variability in terms of measurements. And it does need some sort of expertise before you do some measurements and assess on IVUS. As I already mentioned, there's a good histology correlation for OCT on plaque characterization. And in addition to the calcium and the thrombus, for the lipid-rich plaque, OCT is highly sensitive. You can see the sensitivity is as high as 85% compared to about 60% sensitivity with IVUS. So if you want to study a plaque to see if it's lipid-rich, OCT is a useful tool. And more interestingly, the assessment of thin cap fibroatheroma. As you know, recently there's a lot of interest on thin cap fibroatheroma in assessing vulnerable plaque and plaque rupture in ACS, and also in defining culprit lesion. As you can see in this picture, the thickness of the fibrous cap measured by OCT correlates well with histology, with a good correlation coefficient of 0.9. As I already mentioned, in culprit lesion, for instance, when you have somebody with an inferior MI, you have a tight lesion in the right coronary artery and a codominant left circumflex artery, OCT can identify the fibrous cap disruption, any plaque erosion or thrombus, and clearly it will tell you which lesion you need to treat in an ACS setting. As you know, the recent data is you just treat the culprit vessel and defer the treatment of the non-culprit lesion. This is a very interesting data. Well, what they did was they looked at patients who have already been assessed on IVUS, and the IVUS showed to have 0 stent coverage. And these patients were looked at the OCT, and 92% of these patients where the IVUS showed zero stent coverage actually had stent coverage. It's only about 5% who didn't have, and also in addition to the stent coverage, OCT also detected malapposition in a small group. So when you don't see stent coverage on the IVUS, it doesn't always mean they are at risk of stent thrombosis, as you may miss some neointimal proliferation. As far as data, so I think that the stent coverage data on OCT formed the background for several trials which used OCT to assess the stent strut coverage for various drug-eluting stents, both starting from paclitaxel to the everolimus-eluting stents. And all these studies showed, depending on the type of stents, the stent coverage is completed from between 3 months up to a maximum of 12 months. And there are several ongoing PCI trials currently using OCT rather than IVUS, particularly in assessing bifurcation treatment, left mainstem bifurcation, calcium modification, and for strut coverage. As I already mentioned, there are some new things that we see on the OCT which nobody knows what to do with it or what is clinical relevance. Things like the plaque fracture, there is a cavity within the plaque, dissection. Sometimes you can even see neovascularization within the lesion, and still we don't know what is the clinical relevance of such findings. Tissue protrusion, if you use OCT, you will see that very often. Once again, you wouldn't know whether to post-dilate or not. And for the time being, until further data is available, I don't post-dilate the stent simply for tissue prolapse. The future of OCT is going to involve a 3D OCT. Currently, it's more as on the clinical, on a trial basis. The OCT, as you can see on this picture on the left, and three-dimensional, it shows that the side branch very clearly, and you can recognize the non-jail side branch from a jail side branch. And even with the jail side branch, you can see the stent coverage across the side branch, whether it's in a V pattern or T pattern or H pattern, and accordingly you can decide whether you need to do kissing balloons or switch over from single stent to two stent strategy and so on. But once again, this needs further evaluation. OCT is being studied to assess calcium quantitatively, but again, more data needs, we need more data for that. I just want to finish off with some cases that I did recently, but I thought OCT was very helpful. This is an elderly gentleman who has this very tight mid-LAD stenosis, which, as you can see, it's heavily calcified. And initially, I was planning to do rotablation, but I thought I will probably use an OCT to see the extent of calcium, whether it's intimal calcium, adventitial calcium, and then decide if I need to rotablate or not. And the OCT clearly showed calcification as seen on the angiogram, but as you can see, it's more between 12 to 3 o'clock, whereas subintimal, and the rest of the calcium seems to be more adventitial. This is the proximal to the tightest part of the lesion. And this is the tightest part of the lesion after balloon dilatation. You can see at 12 o'clock already the balloon has disrupted the plaque, and there's not much calcium. Once again, between 9 o'clock to 3 o'clock, there seemed to be some calcium between 4 o'clock to 7 o'clock. So I just went with just conventional angioplasty with balloon dilatation and stenting. As you can see, the stent expansion was pretty good despite all the calcium, and even without using rotablation. And that is the final result. There was some edge dissections, I had to put a longer stent. The stent, the second case, the case where the stent appeared underexpanded. And this is the patient who had a bypass with the grafts to the LAD and right. The circumflex, which is unprotected by the graft, has progressed with this severe diffuse disease. After balloon dilatation, I did OCT, that is the tightest portion on the circumflex. And what it also showed is, once again, which was not very clear on the angiogram, the circumflex lesion was quite calcified, as you can see, between 9 o'clock to 1 o'clock. And after the dilatation, sorry, the angiogram picture didn't load. After stent deployment, angiographically it looked perfectly fine until I put an OCT. You can see the stents are clearly malapose, and after post, and there is also tissue prolapse at 7 o'clock, but after post-dilatation, the stent expansion and apposition was very good. The third case is a case of instant restenosis. This gentleman had PCI to his right coronary artery about 15 months ago. You can see the stent, the mid-RCA, with some evidence of instant restenosis. Angiographically, it's difficult to say whether it's severe or not. Yes, you can FFR it, but with all that proximal lesion, FFR will be significant, and of course you can do a pullback with intravenous infusion, but technically it's not going to be easy, whereas OCT clearly showed a significant neointimal proliferation with a minimal lumen area of less than 3 millimeters squared, and this is for a more than 3 millimeter vessel, and I feel it's significant. This lesion was successfully stented, and you can see 2 layers of stents at 10 o'clock with good stent expansion. And once again, that is the same patient showing good stent expansion. And that is the final angiographic result. There was another stent deployed to cover the proximal lesion. The final case is this patient with an occluded LED, where after stenting, anyway, there was, after opening the LED and stenting, there was this area just distal to the stent, which looked suspicious on the angiogram. It was unclear whether it was spasm, or whether there was a geographical miss, or whether there was plaque shift, and clearly OCT confirmed there was edge dissection in addition to a significant plaque burden. So I had to put another stent on this patient, and that was the final angiographic result. The same patient, he had some left mainstem disease, and there's a single stent across the circumflex origin, and you can see the circumflex origin hazy, looks hazy, although the flow is pretty good. And the OCT assessment of the bifurcation showed a good luminal area at the ostium of the LAD and at the ostium of the circumflex. So I left that circumflex alone. So to summarize, I've just put this slide. I think it probably explains everything. And most, in assessing most characteristics, OCT seems to be better than IVUS, but the only thing OCT doesn't have is the data as much as IVUS does. Clearly, the resolution of OCT is much better. Penetration is probably not as good as IVUS. Calcification assessment, both are equally good. Thrombus assessment, OCT has slight edge over IVUS. Plaque characterization, I think there is good data. OCT characterize the plaque better. And I personally feel OCT is better to assess stent expansion and malapposition and stent coverage. People have always been concerned about OCT in left main, but from my practice, I think left main, OCT shows bifurcation of the left main as well as IVUS. There are some limitations in studying the ostium of the left main, because you need to get the guide cath into the left main to flush the blood away. And if you want to see the ostium by staying outside the ostium, you're not going to get a good flush. So assessing the ostium of the left main, I don't think OCT is very helpful. You need either IVUS or obviously FFR is even more helpful. Bifurcation lesions, yes, 3D OCT, once it's in practice, I think it'll be very useful. You can identify the jail side branch from the non-jail side branch. But the area where OCT is probably not of much use is in chronic total occlusion. So once you have a wire in the false lumen, and say if people with IVUS, you know, sometimes you put the IVUS in a side branch or a diagonal next to it, and you can look at the first wire from the far field, which you cannot do with the OCT because of its poor penetration. So assessing the wire in a CTO, I don't think OCT is very helpful. But as I already mentioned, for defining culprit lesion and assessing the vulnerable plaque, plaque erosion, thrombus, and TCFA, which is a thin cap fibratheroma, OCT is very helpful. But technique for OCT does have an influence. Unlike IVUS, the technique is very simple. You just have to advance the catheter distal to the lesion, and you do a manual or an automated pullback. Whereas here, the timing of injection is crucial. You have to be strong. Don't ask your nurse to do it. They can never inject as strong. And you have to inject it as strong as possible, and make sure that the guide cath is well in the ostium. But sometimes there is a steel phenomenon, the flush goes into your side branch like a circumflex, and you don't get the LED well visualized when you may need to deep throat the guide cat a bit more. So there are some technical limitations, but as with like anything else, with more practice, I'm sure I'll be able to crack it. And in my experience, I noted, although the catheter is lighter and smaller than IVIS, the trackability is not as great in a tight lesion, or certainly in calcified portion. Particularly because of its softness, it can sometimes kink. And the fiber optic cable, once it kinks, it's useless. You're not going to see anything. On the other hand, the learning curve for OCT, apart from the technique, is relatively short as compared to IVIS. You need to have good experience in interpreting IVIS images. Whereas OCT, I'm sure some of you might have already seen on the first day on the demo machine, it's very, very easy to interpret, which I think is a major advantage. I want to conclude by saying, yes, OCT is very good to assess most of the things, but there are a lot of things that you see on the OCT, like tissue protrusion, plaque erosion, cavity within the lesion, and so on. You have to interpret it very carefully. There is always a temptation to treat it with further stenting. You need to resist that, because clearly there is no data now to guiding us how to deal with these new variables. And hopefully in the future, when you'll have more data, we can tackle them. Thank you for your attention.
Thank you, Dr. Amal, for an excellent lecture. It's very clear that, the present-day OCT catheters are very user-friendly, and it can go wherever the 1.5 balloon goes, and it takes 5 to 10 minutes to get a OCC assessment of a lesion. So it's very user-friendly, and the learning curve is much less. Between the OCT and IVS, if you look at the characterization of the vessel and plaque, probably plaque characterization is better with OCT, but if you want to look at the wall and diameter, I think IVS will be better. But the optimization of the post-stent result, I think certainly OCT is better than IVS. I think that is the message that Amal wanted to give it to us.